Hello, this is Wallace Jackmon. I'm the clinical psychology director here at Avera Behavioral Health, and I am going to provide the patient and family education group. The beginning of this presentation will be a brief discussion of how the brain works and its correlation to issues related to mental health, behavioral health issues. One myth that is in our society is that we only use 10% of our brain. That simply is not true. The fact is, we use all of our brain every day. The brain is always active. Even when we're sleeping, our brain is still awake. And so think of the brain as an organ of your body, just like your heart or your kidney or your liver. The brain can also have disorders, just as those organs can have disorders. So let's think of psychiatric illnesses as brain disorders. And often professionals find very little distinction between the two disorder categories because mental and neurological health, they're interconnected. And so now that we know that we're using all of our brain, there's certain portions or compartments of our brain that perform different functions, one of which is the amygdala. It's this kumquat structure in the midbrain, and we will be referring to that area later in this presentation. So behavioral health issues, mental illness, isn't controlled by one specific part of our brains. It involves complex interactions between multiple brain regions, and these different brain regions are interconnected by neurotransmitters. And we'll talk about that as well here in a little bit. The prefrontal cortex of our brain is responsible for executive functioning. Sometimes that's described as the day planner part of our brain. The amygdala plays a role in fear, anxiety, and aggression. That's one of the structures in our brain that provides that fight or flight response we might have when we're scared or frightened. The hippocampus think of that as the library of your brain. So it's involved in memory and spatial navigation. The anterior cingulate cortex processes physical and emotional pain and cognitive control. The limbic system, which is a system of different portions of the brain, is a network of structures that helps regulate our emotions, our motivation, and our behavior. The temporal lobes contain areas involved in language, processing things in our environment through our senses, and memory. So, dysfunction in these regions can lead to a variety of mental health conditions, such as depression, anxiety, schizophrenia, and bipolar disorder. Mental illness is often considered a brain disease because it's associated with changes in the brain structure and chemistry, and it's rooted in complex interactions in a person's biology, their environment, their psychological functioning, their affect, meaning their mood, their emotions, and their behaviors. And so this cross-section picture just simply speaks to certain portions of the brain in which certain disorders are often commonly seen or controlled, which is Tourette's over here to the left, or depression OCD is in this midbrain area. So this is just giving you a general idea of one small section of our brain and its interconnection to different disorders. So now that you are aware that there are different compartments of the brain, there has to be a way for those compartments to speak to each other. The brain has over 86 billion neurons. A section of the brain the size of a grain of sand has 10,000 neurons. Think of neurons as telephone transmission lines, or that they are frayed electrical wires, and they are trying to send information from one part of the brain to another, and to another, and to another. 86 billion of those are in our brain. And so psychotropic medications intervene within those structures of neurons in their transmission of those electrical signals to each other. And if you hear the term SSRI, which is a selective serotonin reuptake inhibitor, such as Prozac, that's a medication, that's a type of medication that changes the volume, the number, the way in which those neurotransmitters work in the brain, which in turn can aid in changing some of the negative symptoms associated with different disorders. This is simply a picture of the DSM-5-TR. It's the standard manual for diagnosing and classifying mental health disorders. It's used by mental health professionals across the United States and across the world, and it's the most critical resource for clinicians working in mental health. It's published by the American Psychiatric Association, and it provides consistent framework for diagnosing different conditions. The text, you can't see it because of my picture, but it has over 650 pages. So there's a lot of disorders in this manual. Now we are going to move into some of the more common diagnoses that we will see in behavioral health, keeping in mind that just because someone has a certain diagnosis doesn't mean they meet all of the symptoms or all the criteria associated with that diagnosis. The other thing is hiding behind my picture speaks to biopsychosocial, referring to that there's a biological, a psychological, and a social component to every disorder or every issue from a mental health perspective. And that's how we look at not only intervening, but treating these individual diagnoses. Generalized anxiety disorder is the most common cause of disability in the workplace in the United States. That's been since 2001, and that still holds true 24 years later. And about 20 to 25% of individuals with depression also have symptoms of anxiety. This means it's very common to have both. And so if you hear the term comorbidity, that's what that refers to, is some conditions are comorbid or common, that they tend to run together. They tend to be what I describe as ugly cousins. They tend to be kind of connected. And so 1 in 4 individuals, depression or anxiety, also have depression or anxiety. This is simply a list of some of the common DSM-5 anxiety disorders. I'm not going to read through every one of these, some of which you may already have heard of or been familiar with, such as panic disorder or agoraphobia, perhaps trichotillomania, which is folks pulling out their hair, or a hoarding disorder. All of these are under the umbrella of anxiety. Generalized anxiety disorder, these are the DSM-5 criteria, is excessive anxiety and worry that happen more days often than not for at least 6 months about a number of events. And so the difficulty is individuals with this disorder find it difficult to control their worry. And it has at least 3 of the 6 symptoms on the right side. One thing I want to say about this is we know everybody worries. So this isn't a helpful thing to say to your loved one, like, well, everybody worries about things. That's not the same as an anxiety disorder. Anxiety disorder means that they cannot control that worry. So when I'm worrying about the economy, or worried about my 401k, or worried about getting new tires on my car, everyone has those kinds of worries. But if somebody tells me, well, Wallace, don't worry about that, I'll be like, oh, okay, and I can put it on the shelf. Somebody with an anxiety disorder cannot put it on the shelf. So it's please keep that in mind, that if you're working with somebody with an anxiety disorder, one of the worst things you can say to them is, well, just don't worry about that. They can't, because if they could, they'd stop doing it. That's why it's an anxiety disorder. And it's accompanied by 3 or more of the following, which is restlessness, fatigue, poor concentration, irritability, muscle tension, or sleep disturbance. Another common diagnosis is dysthymia or dysthymic disorder. It's been renamed persistent depressive disorder since the DSM-5 came out. And so it's 2 or more of the following, which is poor appetite, sleep problems, fatigue or energy issues, low self-esteem, poor concentration, difficulty making decisions, or feelings of hopelessness. I put this picture of Eeyore. You can't see Eeyore's face because of my picture, but Eeyore from Winnie the Pooh could possibly be described as having dysthymia, meaning that he's still able to go out and see Christopher Robin and see Tigger and see all of his folks, Winnie the Pooh, but he's just moping around and just like glum and hard, don't want to talk to anybody. And that's what dysthymia is. It's just gloominess. Next is major depression. In the United States, major depressive disorder has an estimated lifetime prevalence of 16.2%. That means that individuals in the United States, about 16% are going to have some symptoms of a major depressive disorder throughout their lifetime. And so anxiety disorders, I said earlier, second leading cause of disability, but we're also noting that that's become much more disabling for adolescents as well. So major depression is different than Eeyore and dysthymia. It's different because it's a depressed mood more days often than not, feeling sad or empty. So that's similar to dysthymia. But it also has anhedonia, which means it's difficult for people to experience pleasure. Like things that used to be fun, they just don't even really care about anymore. It's also connected or correlated with appetite disturbance. So we're looking for 5 of these 9 symptoms for a major depression. Remember, with dysthymia, we're only looking for 2 out of those 5. We're looking for 5 out of 9 for major depression. So depressed mood, anhedonia, sleep or appetite disturbance, sleep disturbance, psychomotor agitation and or retardation. That means being really, really agitated or just really slowed down and just can't hardly even lift up my arm. Fatigue or loss of energy nearly every day. Feelings of worthlessness or inappropriate guilt. The person just feels guilty for stuff that's not even their fault. They have absolutely no control over it, and they're feeling guilty or worthless because of it. Poor concentration or indecisiveness, can't make decisions, hard to concentrate or focus. And then suicidal thoughts. That's one of the most common symptoms. Without a plan, you don't necessarily have to have a plan, but suicidal thoughts or an attempt or maybe a plan for committing suicide. Remember, 5 of those 9 criteria to meet for a major depressive disorder. This slide refers to bipolar disorder, and I just put a brief description of mania or hypomania, the difference being how long these symptoms occur. Mania lasts longer, generally speaking, and is more severe than hypomania, but they have the same symptoms. And so bipolar disorder, bi means 2. Bicycle, right? There's two wheels. Well, bipolar means there's 2 poles. One pole is major depression, which there we go, that we just went over. That's major depression. And the second pole is mania or hypomania. Okay. And so, person with bipolar disorder has both of those. They don't happen at the same time, though. They happen at different times. One time the person's manic or hypomanic, and then they fall into the depressive pole. And then they might be depressed for 3 or 4 or 5 days, and then they move back to that mania or hypomanic pole. And mania or hypomania is a period of feeling high or overly happy. They're irritable, they're agitated, they're jumpy, they're wired up, they're major behavioral changes. They're jumping from one idea to another. I've often described they'll have 15 projects going on at the same time, and none of them get finished. They're easily distracted. They're restless. They don't sleep. They might only sleep 2 hours and feel fully rested the next day. And this might occur for 3 or 4 or 5 days in a row. They have these unrealistic beliefs about their abilities that they can, I can build an airplane. They have different ideas that are just completely not realistic, and they might have high risk behaviors like spending sprees or impulsivity, impulsive business decisions, and so that would be a manic or hypomanic episode. Next is trauma and PTSD. The definition of trauma is defined as exposure to death or injury, sexual violence, and it occurs directly or it could be indirectly of a person witnessing an event or repeated exposure to distressing details. That's what's behind my picture. The term ACEs refers to trauma, which is adverse childhood experiences, meaning over 70% of individuals experience a traumatic event at least once in their lifetime, with approximately 10% developing post-traumatic stress disorder as a result. Um, what does 70% mean? Like some people are, well, I don't even know. Who cares? What does that mean, right? It means that if there's 10 of you in this room right now, seven of you will have experienced a traumatic event at least once in your lifetime, and one of the 10 of you will develop post-traumatic stress disorder. Think of it that way. That also refers to your church. If you've got 100 people in your church, or you've got 100 people at your place of employment, 70 of those people, of those 100, will experience a traumatic event at least once in their lifetime. Other types of trauma or adversities include bullying, that can be online, at school, at your place of employment, community violence, natural disasters, refugee or wartime experiences, or witnessing or experiencing acts of terrorism. Symptoms of trauma may include, but not be limited to, dreams or nightmares, or flashbacks, or intrusive memories of the trauma. Hyperarousal is often common manifestation of trauma, meaning the person is like hypersensitive to anything that triggers those past memories. And so they may have this constant expectation of impending doom or harm, distressing dreams, sleep disturbance, exaggerated startle response, poor concentration of activities not even related to potential danger. So, like one of the most common ones you might have heard before is maybe veterans or someone that was exposed to wartime trauma, and it's the 4th of July and fireworks are going off. In your brain, we know, okay, that's just fireworks, but that can be triggering to an individual that has not resolved their past trauma. So, coming back to different portions of the brain, we're going to be talking about the sympathetic nerve system and the amygdala. That little kumquat structure in our brain is part of that nerve system and puts us on a state of alert whenever there might be danger. So there could be a stressful situation. The hypothalamus secretes a hormone, and then that stimulates secretion in different parts of our brain, and that activates us to fight or flight. And so that might provide intense feelings of fear or panic. And so trauma affects a person's ability to remember events. They may become hyper vigilant, maybe more irritable, and they disconnect symptoms from the actual source or from the actual occurrence of what's happening in the here and now. Psychosis and schizophrenia, I'm using interchangeably. Psychosis is not an actual disorder, but it's a summary of different symptoms associated with schizophrenia and or other disorders. So a person can have major depressive disorder with psychotic features. And psychosis or psychotic in behavioral health does not mean somebody that's terrorizing people or is going to be a school shooter. That's not what psychosis means. It means delusions, hallucinations, disorganized thinking, disorganized behavior, and negative symptoms. That the person has difficulty distinguishing reality from their perceptions. Just to give you a kind of Cliff's Note version of psychosis, or an elementary school version, is you can develop some symptoms of psychosis if you go 3 or 4 days without sleeping. There's been plenty of research to support that, which is one of the reasons we're always asking people how they're sleeping. But there's been plenty of studies that show if you go 2 or 3 or 4 days without sleeping, you may develop some of these exact same types of symptoms. So I won't go through all of the criteria for schizophrenia. It's not one of the most common diagnoses we have, but I think it's worth knowing what some of the psychotic symptoms are, because they can be inherent, like I said, in major depressive disorder and or a few other disorders. So a delusion is a false belief about something. I had one client that thought that the devil was in electricity. And so that's just a false belief. Hallucination is hearing things, seeing things, smelling things, feeling things that other people don't see, feel, hear, or smell. Disorganized thinking or speech is they're not thinking logically, so they'll have like word salad or a jumble of words together in a sentence that don't make any sense. or disorganized behavior. So they're acting unusually and in strange ways that people don't completely understand, and that may manifest itself by being confused or agitated, or a significant decline in their personal hygiene or self-care. And then negative symptoms include a loss or reduction in normal functions, such as they don't have any motivation, reduced emotional expression, or withdrawing socially and becoming a hermit. ADHD, referring to the symptoms of inattention, attention deficit hyperactivity disorder, is they have trouble paying attention, making mistakes, difficulty organizing activities, don't seem to listen when spoken to. They might avoid things that require a lot of effort mentally, becoming easily distracted, forgetful in their daily activities, failure to finish tasks, and poor follow through on decisions. One misnomer is people call it ADD. That's not in the diagnosis, a DSM. There's no such diagnosis. It's one of these social terms that people have thrown out. But the correct term is ADHD, and it's either inattentive, or it's hyperactive, or it's a combination of hyperactive and inattentiveness. ADHD with impulsivity or hyperactivity is they talk excessively, driven by a motor, running and climbing all over the place. Usually, you think of children in that realm, or fidgeting with hands, they're squirming in their seat, blurting out answers before questions have been completed, difficulty waiting their turn, throwing temper tantrums, and interrupting or intruding on others. So in 2014, Bott and Paris indicated that research indicates the sole use of self-report questionnaires or checklists is not recommended in the assessment of ADHD due to the high potential for false positives. That means that people can fake good on those reports, and generally speaking, one report, and that it says right here, no single test can be used as a sole measure to diagnose ADHD. So this refers to the people that might see a provider and they give them one sheet and they check it off and they're like, yep, you're ADHD. No, research supports that's not what you're supposed to do. And if you're going online and like you're having your cousin check some, Bill's ADHD website, no, that's not. Research does not support doing that. It's multiple questionnaires and interviews, strong clinical interviews, possibly even including electronic testing to determine if someone's ADHD. About 20 to 40% of folks with ADHD have comorbid anxiety disorders, with GAD, generalized anxiety disorder, being the most common. Spoke about comorbidity earlier, meaning those ugly cousins, they tend to be often connected with each other. Means two, if you have 10 people with ADHD, 2 to 4 of them will also have an anxiety disorder. In addition, GAD tends to coexist with other psychiatric disorders. The most common ones are major depression, bipolar disorder, I said anxiety disorders earlier, and substance abuse problems. Some researchers have gone so far as to say sometimes people are using substances as a means to self-medicate for an undiagnosed anxiety disorder. This chart is just to give you a brief lesson on the comorbidity between GAD and major depressive disorder. Meaning, here's the symptoms on the left side of generalized anxiety disorder. Here's the 9 symptoms for major depressive disorder. Note that there's 4 that are closely related to the other ones. So, for example, sleep is a problem with anxiety, and sleep, diminished ability, concentrate, or insomnia, or sleeping too much, is also for major depression. So again, they kind of correlate, they connect with each other, and that's called comorbidity because they share similar symptoms. Now we're moving on to risk factors and etiology, meaning like how did it start? Where did it begin? Where did this come from? That's what etiology refers to. And before I get to that, I want to go back to about the comorbidity, about anxiety and depression, and they be comorbid, or ADHD being comorbid. Is keep that in mind too. Is sometimes folks will say, well, God, I got major depressive disorder, and I got anxiety, and I have ADHD. Well, that's not uncommon. So don't overemphasize that as being pathological, like this problem must really have some bad problems if they have 3 diagnoses. Not if they're comorbid. those tend to kind of go along with each other. And so here's some of the risk factors for GAD. Is genetics plays a big role, meaning that if somebody else in your family had anxiety, a higher likelihood that you may have that. And anxious parents may genetically predispose their children to anxiety by modeling anxious behaviors and behave and or parent in ways that encourage and maintain anxious behavior in the child. What does that mean? It means just what this cartoon is showing. It's the first day of school, and these frightened parents over here are saying, whatever you do, don't let him sense our anxiety. And you can look at this kid, he hears it, and he's going into the playground, and he's likely more anxious because his parents exhibited that. So that's what that research is referring to. If you're doing that as a parent, try to cut down on some of that. Additional risk factors for developing or exacerbating anxiety disorder is tobacco smoking, um, as well as excessive caffeine use. That's also been linked to anxiety disorders. Social media. This is one of my specialty areas. Been studying this for the last 12 years. There's a distinct correlation between depression and anxiety, meaning that the more you spend time on social media, the higher likelihood of depression and or anxiety. It can also cause problems with your sleep. Um, um, it can also cause problems in your relationships, your ability to focus and concentrate. So please, if you're spending more than 2 hours a day on your smartphone, and I mean just perusing social media sites and whatnot, you want to cut back on that. 2 hours is the maximum. We know that it can be linked to some of these disorders we're describing. Excessive demands at work can play a significant role in being more of a risk factor for some disorders, most notably anxiety and mood disorders. It should come as no surprise that financial problems can increase the risk of depression or anxiety. Relationship problems, whether it be husband and wife, boyfriend and girlfriend, mother and father, mother and son, any relationship problems could also exacerbate an already existing mood or anxiety disorder or provoke one to cause one to occur. Children and family. It's not saying that children cause anxiety and depression, although in some cases that might be true. Yet it causes more stress. Anyone that has children in the audience knows having children is a stressor. No matter how well behaved they are, they can still be a stressor, and that can exacerbate mood or anxiety issues. Health problems is a contributing factor to mood and anxiety disorders. Sometimes it's the chicken or the egg issue is, did the health problems cause you to have the anxiety or mood disorder, or did you worrying too much and having a mood disorder lead to you having a health problem such as gastrointestinal distress or acid reflux or migraines or headaches? Okay, so health problems are distinctly correlated to being a risk factor for mood and anxiety. This one may come as a surprise to some people, yet vacations and holidays are a stressor. They are a risk factor. We see a higher acuity or a higher intensity of problems for our patients around the holidays. There's expectations that don't get met. You have to have more money if you're going to be doing a lot of Christmas shopping and that kind of thing, or a vacation, you have expectations and sometimes they don't get met. That can increase a person's distress. I alluded to the genetic predisposition earlier, meaning that if there's a family history of a bipolar disorder or paranoia or schizophrenia or depression, that puts the other members of that blood family at risk of developing similar or same disorders. It doesn't necessarily mean they're going to get those disorders, it just puts them at higher risk. As I also mentioned earlier about sleep disturbance, sleep plays a significant role and can be a risk factor for anxiety or depression. Think of sleep as a way for your brain to reboot itself, that the brain needs that rest to be able to reorganize all that information that it gathered throughout the day through your five senses. And so if you don't get enough sleep, your brain becomes dysregulated and it doesn't have the opportunity to compile that information in the areas it's supposed to go, and then it can manifest itself with increased pathology. This one should not surprise too many people, that substance abuse, we talked about tobacco and caffeine use earlier, but alcohol, stimulants, or even abusing over the counter substances or prescription substances certainly put people at a much higher risk for developing a different or an additional um, behavioral health diagnosis. And so, what do we do about it? Well, we use evidence based treatment. Evidence based treatment refers to there being evidence through research that supports the treatment you're performing is going to help you. And so, we know from evidence and research that aspirin or acetaminophen may be helpful in treating headaches or physical pain because there's been lots of trials of research. So the same holds true for behavioral health diagnoses. Is there research to support what it is that you're doing? And one of the most common evidence-based treatments is cognitive behavioral therapy, or CBT. We also know that SSRIs, which I referred to earlier, is the first line therapy for GAD and for some personality disorders. Benzodiazepines have been known to be helpful for some forms of anxiety, but they're only supposed to be used short term. Psychotherapy, there's been some research that says psychotherapy is as effective as medication, and as effective as medication. Just leave it at that. So CBT, you may have heard, may not heard of it. We have CBT groups here on several of our inpatient units. It's a very simple concept. Refers to how negative thoughts lead to negative feelings, and negative emotions lead to negative behaviors. And I guarantee you, if you behave negatively, something happens to you negatively, you're likely going to have a negative thought. And so they go in a circular kind of pattern like that. And so the key is recognition of negative thoughts and reframing or restructuring those negative thoughts. That's a simple explanation, yet it is a little bit more in depth insofar as helping individuals. Here are a few other evidence-based treatments for some of the disorders we've referred to: mindfulness, guided imagery, DBT. I put the ones in bold that they have the most efficacy or the best research behind them. DBT, somewhat. ACT is acceptance and commitment therapy. Humanistic or person-centered, sometimes it's called Rogerian therapy. Talk therapy. Exposure-based treatments, typically used for PTSD and for OCD and some other anxiety disorders. Behind my picture is letter writing, diaries of feelings, distraction, and self-soothing. One other thing I want to say about evidence-based treatments is often use the example when I used to do some teaching, is that a non-evidence-based treatment would be if I said something such as, hey, if you eat 3 cheeseburgers a day, that'll get rid of your depression. Well, are there any research studies to support eating 3 cheeseburgers a day will relieve someone of their depression? I can tell you there is not. So that is not an evidence-based treatment. What does that mean to you as a loved one or a family member or a patient? You want to make sure that when you see somebody for outpatient therapy, they are providing evidence-based treatments. There's people in this community and across the United States that are providing treatments that have absolutely no research to support their efficacy when helping you. And it might as well be cheeseburger therapy. So make certain that there is research and evidence to support the type of therapies and treatments those providers are giving you after you leave the hospital. One of those is they're suggesting you should activate yourself behaviorally. Research supports that. Muscle relaxation, diaphragmatic breathing, pleasant imagery, yoga, meditation. Behind meditation is prayer. There's research that supports prayer can be helpful for people. Coping skills, the correct kinds of coping skills, music, reading, and then exercise. In some studies, exercise has been shown to be as effective, if not more effective, than some types of medications and therapy combined. So if you want to get better right away, start exercising. And this final slide is says what to do and not to do, but I put it. I didn't want to end on a bad note, so I said what don't do first, and what you should do. So don't call the patients or call yourself names or blame yourself for things beyond your control, and don't offer unsolicited advice to people. And please don't trivialize or what I call therapize. Try to therapy your loved one coming out of the hospital, or saying things like, "Oh, just snap out of it," or "Look on the bright side," or "Could be worse." Calm down. Relax. It's all in your head. Or stop worrying about that. Everybody gets stressed out. I get stressed out too. Don't do that. Or I get anxious too. You just need to get over it. Let it go. That's 10 years ago. You should let that go. Don't do that. That's a big no-no. Okay. You should try to do just this. Don't do that. If you say you should go see your therapist, okay, that's a different thing. But or you always do this. It's not that big of a deal. Let that go. Don't even worry about that stupid stuff. Don't say that to someone with a mood or anxiety disorder. So avoid those types of statements. What you should do is listen without judgment. Just be a good listener. Just be there. And encourage them to take their medication as prescribed and follow through with therapy, especially at the times they don't feel like going. One statement I've always said is you can't wait to feel better to do something. You have to do something to feel better. So you can borrow that one if you'd like. Encourage them to get involved in activities, but still, even if they say, no, no, I'm not doing it, you still want to listen, offer emotional support. Um, if you're a patient, and I encourage you to practice self care. Sometimes I call that extreme self care, that you really want to crank up the self care even more. Understand suicide risks and other symptoms. And if you're a loved one, ask that individual how you can help them. How can I help you? What can I do to help? Just ask them. It might be something simple as, can you just watch this TV show with me? Or can you just go to the park with me? Oftentimes it's not, something huge or monumental. It could be something simple. Just ask them what you can do to help. And then in closure, I would just say be patient. Um, Maintain support of those individuals, and stay in contact. Don't, when they get out of the hospital, don't stay in contact for a day or two and then they don't hear from you until the 4th of July. No, stay in contact with them consistently by email or a phone call or a text message. Just say hi, drop them a postcard, something, just to let them know that you still care and that you're still there for them. I appreciate you all taking the time to watch this and attend this. It's telling me that you care about your mental health and or the mental health of your loved one or the individual that you know here in the hospital, and keep some of these points in mind. And I appreciate having you here, and goodbye. Reference page number 1, reference page number 2.